Good afternoon, everyone. My name is Janet Watson, and I'm with the Community Technical Assistance Center, and I would like to welcome you to today's webinar, Borderline Personality Disorder in Adolescent. But before we get started, I want to take a moment to orient everyone so you will know how to participate in today's event. Please note that upon joining the webinar, you have been placed on mute to avoid any background noises that may distract others from listening to the presentation. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You will have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature. Click the dialog bubble on the toolbar at the bottom of your screen to open the chat feature. In order to ensure that we are able to answer as many questions as times permit, we are requesting that you send in your question at any point during the webinar, and we will address them during the Q&A portions of today's presentation. We are very excited today to have with us Blaise Agari. He will be our presenter for borderline personality disorder. And wow, he's going to then introduce himself, and you are in for a treat. So just sit back and relax and enjoy. So I'm going to turn it over once again to Blaise, and he will introduce himself of the great work that he's doing. Blaise.
Awesome. Thank you so much. I remember when you first reached out to me many months ago to give this talk. I was very excited by the work that you were doing, and just appreciate being invited to talk, and all the great work that your team has done in helping put all of this together. You might not know this. So my eldest son, told me that he'd wanted to go to medical school, which, I supported. I'm a psychiatrist, I'm a physician as well. And after graduating from college, he said, you know what, I am going to go and become a social worker. And he is now at Boston College in the Latinx social work program. In his second year of becoming a social worker. And I said, well, why did you change from wanting to be a physician to be a social worker? And he said, Dad, I had to think about this. Did I want to be a doctor, or did I want to help people? And he said, I wanted to help people, so I'm going to become a social worker. So I thought it was just absolutely fabulous that, what his thinking was, that people, jump in much, much earlier to help those who struggle in the ways that we see. One thing that he showed me recently, I'm not of the TikTok generation, but he showed me that there was a recent publication or evaluation that a lot of people, young people, are getting a lot of their information about mental health from TikTok, and that I think it was maybe a Wall Street Journal report, 3.7 billion, there was the hashtag borderline personality disorder, BPD, was used 3.7 billion times, which was more than bipolar disorder and depression and anxiety combined. So it was startling to me, this whole question about borderline personality disorder. We want you to start with this poll question. How comfortable are you with making the BPD diagnosis in a person under age 18? So if you can actually answer these questions. I started this program to treat the kids that we see with borderline personality disorder in 2007. And since that time, we've had about 5,000 patients come from all over the world to get treatment. Many of them had multiple hospitalizations, with a lot of self-injury, a lot of comorbidity, PTSD and OCD and other diagnoses. But they've often felt very, very unseen by the mental health profession, very misunderstood by the mental health profession, discarded by the mental health profession, and found kind of an oasis of care and compassion in the work that we did. So, all right. So let's just see. Okay. I see. Okay. I think okay. So you're sharing the results. That's fantastic. Brilliant. Okay. I'm actually very happy to see the number of people who are either very comfortable or neutral or comfortable. Quite a few of you are uncomfortable. But anyway, let's just talk a little bit about this and why it's important. So I'm going to, I think, stop sharing. All right. Share results. Stop sharing. Okay. All right. Let's see here. So what we're going to do is I'm going to get through the first 20 slides. The first 20 slides are about this question of the diagnosis. And what I'd like you to do is, as you think of questions and as questions come up, just put them in the chat, and then my colleagues will at CTAC will collect them, and then we'll review after the first 20 slides. And then the next part, there will be a little bit on research, and then the last section will be on treatment. We'll talk about treatment options. So I want to really review borderline personality disorder symptoms as they apply to adolescents, to review why clinicians may be reluctant to diagnose BPD, to consider effective treatment modalities for BPD, and just some ideas for caregivers to support young people with BPD. Okay, now, so this is where things started for me. Is that McLean Hospital is very famous for treating people with borderline personality disorder. And when I first came to McLean in 2000, as a young resident, I would start asking questions like, you know, this person has the diagnosis of borderline personality disorder. Maybe they were 30, and I'd ask them when their symptoms started. And I never met a single person with adult BPD who didn't tell me that their symptoms started in their teenage years. And I asked them, well, did you get treatment in your teenage years? And you know, often they would say no. You know, people thought we were misbehaving, etc. And then it was only later on that the diagnosis was used. So it seemed to me somewhat preposterous to think that you had to wait until age 18. Now, by the way, I also used to do this because I looked in the DSM, and nowhere in the DSM does it actually say that you have to wait until 18 to make the diagnosis of BPD. I used to walk around with $1,000 check at conferences. So the first person who shows me that that exists in the DSM gets a check for $1,000. And no one ever got it because it does not say that in the DSM. And people on their 18th birthday said they felt exactly the same the day before. So this idea of this cutoff made little clinical sense. The other thing is that, you know, it's not as if anybody who's got siblings or their own children recognize that personality evolves in children. You know, different children have different personalities. It's not that you have these robotic children and then at 18 they suddenly turn and have their own personalities. So if you can have a personality as a child, you can have a temperament as a child, that you can certainly have disturbed personality traits as a child. Psychiatry has been very comfortable diagnosing almost every other DSM condition in younger people. So why not a personality disorder? And here's the thing that actually got to me the most, is that when I spoke to these older people with borderline personality disorder, you know, a condition where if you're hospitalized with BPD, the risk of suicide is about 10%. Consider an emotional pain so intense that only self-injury or suicide feels like a solution. And I mean, if you were to think about the worst day in your life from an emotional perspective, a very, very painful day. And I said, okay, that's it for the rest of your life. But if you self-injure or you make a suicide attempt, then you will relieve that emotional pain. Might you consider that? So, but one of the things that my patients would often say is like, people don't see emotional pain. They see self-injury, they see broken bones, but they don't see emotional pain. And okay, so the DSM says that in young people, borderline personality disorder in adolescence is defined as a one-year pattern of immature personality development with disturbance in at least 5 of the following domains. So let's look at these domains and how they apply to adolescence. So it's not that, yesterday somebody felt abandoned or that their mood was up and down. There has to be a one-year pattern of what the DSM says is immature personality development. This is the type of young person that we see in our program. This sort of 17-year-old, we have had, young people as young as 13 or 14, certainly up until 18, 19, 20. She's had a kid with multiple emergency department visits. She's had hospitalizations for depression. And by the way, I'm using she here. This was in the early days, we had only people who identified as female. Now we have, neither of our programs are identified as gendered. We're gender inclusive. But for the sake of this presentation, depression, suicidal ideation, self-injury, often very bright. A lot of my parents with these kids say, this kid is really bright. How can she have a personality disorder? Or how can she not know that these behaviors are bad? But I say, if you have diabetes or you have asthma or you have rheumatoid arthritis, you can be bright. This is not a problem with intelligence. It's a problem with emotion regulation. This feeling of being disconnected, not having a stable friend group. At times we'll use drugs and alcohol on occasions. And often when she's alone, that romantic relationships are often short-lived and at times can be abusive. That drugs, alcohol, and self-injury frequently are used to regulate how she feels in the moment. And this is a pretty key distinction. I was once at a conference and a very senior psychiatrist said, this sounds like adolescence. And I was thinking a little bit about his statement. And I said, well, okay, imagine that you have 2 kids, twins even, one with borderline personality disorder and one without, and they're both using drugs. Maybe they're having sexual encounters, etc. But the thing about people with BPD is that they'll use the sexual encounters, the drugs, the alcohol, and the self-injury in order to regulate how they feel. So the function in typically developing adolescent is experimentation. The function in somebody with BPD is to regulate how they feel. They have this intolerable sense of self-loathing. And this breaks my heart that these very talented young people hate themselves as much as they do. Often they feel very ashamed of some of the behaviors that they do. And then there's this vicious cycle because they feel so much shame. And then what they do is they start using these behaviors to reduce the amount of shame that they feel. My staff and the parents of these kids will often say how remarkably attuned they are to nonverbal communication. They seem to be able to pick up on other people's inner thoughts quicker than they are themselves. So historically, clinicians saw BPD symptoms in adolescence as either an extreme variant of normal functioning or solely a reflection of poor parenting. So there was always someone to blame. And the adolescents were seen with BPD were seen as promiscuous and manipulative, and these are two of the many words that we banned on our unit, partly because they're not clinical. These are not clinical terms. Somebody has high blood sugar, you say hyperglycemia or high blood pressure, hypertension. But promiscuous is not a clinical term. Manipulative is not a clinical term. So we describe behavior as behavior. BPD was a condition that clinicians refuse to treat. Even today, there's a very high prejudice against treating people with BPD. And I've had patients who are very suicidal say that they won't tell the people that if they are applying for mental health services in the clinic, they won't say that they're suicidal or that they have BPD because it'll be one of the conditions that is excluded from the services offered. BPD emerges in adolescence, about 1 to 3% of community dwelling teenagers and up to 3.5% of young adults. In inpatient units, and we see this, certainly on our unit, we see much higher than this because that's what we treat, but even on just general adolescent units, if you use one of the measurement scales like the McLean screening instrument, MSI, or the ZAN BPD, you'll see that about 50% of inpatients have BPD. Okay, and then in the next slide, so now we're going to see how do we apply the DSM-5 criteria to adolescents. Okay, so the first criterion is frantic efforts to avoid real or imagined abandonment. Now, probably very few people on the screen would want to be abandoned. Sometimes, my kids, I love them dearly, but when they're annoying me, I say, okay, abandon them, but not really. I do love them, but teenagers can be a tough bunch. So what do we see? We see that these kids are often hospitalized because, for a suicide attempt after a breakup with a romantic partner or rejection by a close friend or peer group. And this sense that they will be abandoned by someone essential to their well-being, and the frantic efforts are that then they start bombarding the person with texts, with messages on social media, with phone calls, and they don't leave the person alone. And so one of the problems with this is that often the very behavior that they do to prevent the abandonment, the frequent texts, becomes so aversive to the other person that eventually, even if they had no intention of abandoning the person, they leave the person and then they effectively get abandoned. And then what happens is, say somebody goes to the hospital because of suicidal behavior and self-injury, etc. And then the loved one says, oh my goodness, I didn't realize how much you were suffering. And then they show up at the hospital, that can reinforce the suicidal behavior. So these frantic efforts to avoid this abandonment are often repetitive, intrusive efforts to get somebody that they care about to reassure them that they still care about them. Unstable relationships. So these are characterized by extremes of idealization and devaluation. And as a psychiatrist, I used to be a lot more on the devaluation side of things. I can now get idealized at times, and these are just states of a person's own internal emotional state. And what tends to happen is that during episodes of anger, and parents and clinicians will describe this, a parent or clinician can be vilified. You're the worst therapist ever. You're the worst parent ever. I absolutely hate you. I'll never speak to you again. You should go back and get another degree because you're terrible. And then, when you're there and you're supporting them and they're feeling down and out, then, you're the best person that I've ever seen. You're so absolutely wonderful. And so you can see this flipping back and forth. And it's a reflection of this all or nothing thinking, or black and white thinking. Back in the day, there was a concept called splitting. We don't use it anymore. We talk about polarization. Splitting was a psychodynamic term that came from the idea that there was an unconscious self that sort of saw people in good and bad ways, and that good was projected onto one person and bad to somebody else, and then those people were divided. But from in a contemporary way of thinking about borderline personality disorder, we often see that this is a reflection of just extreme mood states. And as a therapist, again, you can have the assignation, which is alternating between good or bad descriptors. The unstable sense of self. Now, this is a slightly harder criteria to apply to adolescence because adolescence is a time of really, identifying who you are, sort of understanding yourself. And we see all sorts of things, whether it's clothing or makeup or dress or politics or religion or whatever it is. But one of the things that we see in these adolescents is this profound and enduring self-loathing as a core self-construct. The other thing is that they have this sort of chameleon-like sort of presentation where they're so desperate to want to fit in that they readily change to whatever the in-group is or whatever a group is that's going to accept them. So I've actually seen people who've violated their own political values to fit in with a group of people just because they're so desperate to fit in. And then they often say, I just wish that I had a better sense of self, that others have a better sense of self than I do. Dangerous impulsivity, in the DSM, they talk about, impulsive driving, impulsive spending, impulsive drug use, and obviously in younger adolescents who are not driving, who may not have access to drugs and alcohol, you might not see as much, recklessness in that way, but you can see other impulsivity in terms of running away from home, in terms of dating older people, experimenting with drugs at an earlier stage. And one of the, I think, really sad things that we've seen in terms of the impulsivity is that this desperation to feel wanted and to feel loved is so powerful that some of these younger adolescents, quite young, 12, 13, 14, will hook up with older people just to feel connected and to feel wanted. And it's just so tragic often when that happens. Recurrent suicidal ideation, suicidal behavior, ideation, and self-destructive behavior. We see a lot of self-injury. And actually, I mean, self-injury in and of itself is not singularly kind of important in making this diagnosis. And there was a paper that between 1 in 4 and 1 in 5 people in Ivy League schools are self-injuring. But nevertheless, we see this in almost every single kid that we admit, a lot of cutting. We have seen burning, head banging, punching walls. We've seen very significant suicidal behavior in terms of overdoses, guns, hanging, and other behaviors like that. Again, the behaviors can be reinforced by the well-intentioned attention of caregivers. In other words, if a child gets very deep attention by doing these behaviors and people are overly solicitous about them, they might be able to, then increase the behavior if that's something that they want. But let me just say one thing about this. Our research shows that self-injury as an attention-seeking behavior is very rare, actually. And most people say, oh, they're just looking for attention. Attention-seeking occurs in about 10% of cases. So it's not to say that it doesn't occur, but often when people self-injure, it relieves emotional pain. But just think about how much emotional pain you'd have to be in that self-injury actually feels better. And what we know about tissue damage is it releases endogenous opiates in the brain, and that often quells the anxiety or the strong emotions that show up. And if you think about, I mean, if you get bitten by a mosquito or something, you know, you scratch yourself, that you scratch the skin, and that sends soothing messages to the brain. Well, this is sort of an extreme form of that in terms of self-injury. These young people say that they feel things quicker with less apparent provocation than others do. They feel things more intensely than others do, a slower return to baseline than others do, so that they're more emotionally sensitive. Now, to me, it's a very beautiful thing to be emotionally sensitive. And actually, many people who enter our profession would not be able to be in our profession, in the mental health profession, if we were not emotionally sensitive. But it's almost like you're giving, an adolescent, say, the motor engine of a Porsche car without knowing how to drive it. It's not so much that they have a powerful emotional engine. It's just that they don't know how to use it. And so what happens with these adolescents, different from people who are emotionally sensitive and know how to regulate that, is that their behavior is often mood dependent. So what will happen is that when they're in a good mood, they can get things done. But when they're in a bad mood, they can get almost nothing done. And imagine that, on days when you were having when you were in a bad mood, or you were angry or upset, you just didn't go to work. That would be very disruptive in your life and the life of others. And so there's a reactivity to mood. Now, people often say, well, isn't that just bipolar disorder? Now, the difference is that these episodes are often in minutes, hours, maybe a day or so, but they rarely persist for 2 weeks. Once they're persisting for weeks, then you have to start thinking if they've got an elevated mood about bipolar, or if we're in a depressed mood, bipolar depression or depression. These are often reactive states. So someone didn't call me back, I got a bad grade, feeling unloved, and it's often interpersonal between the person and somebody else, or intrapersonal, something that they're thinking in their head. So there's a massive reactivity of mood. Chronic feelings of emptiness. Many of these adolescents say that they feel empty inside. This is often expressed as a feeling a lack of connection. And what's sad and interesting is that often this emptiness or this lack of connection can be relieved by doing risky or intense behaviors. So often if there's an intense connection through drugs or sexual relationships, that can temporarily alleviate the emptiness. And so you can see why that would be so reinforced. But they can often feel very alone, even if they're in a group of people, even with people that they consider their friends, because that they see that the world does not see the world the way they do. Anger regulation problems. This seems to be one of the reasons why parents bring their kids in, is that these children become very, very angry. Now, what's interesting about this is that the fights often occur mostly with those people closest with the BPD adolescent. So we've had situations where schools would say, oh, this is a perfect student. We don't know what the parent's talking about. But then when the kid's back home, they're having fights with their parents. So the parent feels, crazy or not, or misunderstood or unheard. And so the closer that you are to the BPD person, the more intense the emotions and the more likelihood that anger is going to show up. And it can take the form of destruction of property or physical aggression, but often there are these very hurtful verbal attacks. And even my staff will say they seem to know the thing about you that you're most upset about. Maybe it's your own self-doubts, maybe it's something physical, but they will often say, like pretty mean things during their own episodes of anger. Anger is often a secondary emotion to sadness, but because they can often not tolerate sadness, they will rapidly become angry. And And there are other times when the anger isn't expressed outwardly, but it's internal, that they're just seething, they're sort of seeing the world as unfair and unjust and just ready to explode. Paranoia and dissociation. People often say to me, well, wait a second, isn't this just a form of trauma? Trauma, in our research, about 50 to 60% of people who come to our program with the diagnosis of borderline personality disorder have experienced trauma. I think about actual formal diagnosis of PTSD is less than that. Certainly people with BPD are at risk of developing people with BPD are at risk of developing PTSD, because if earlier on I mentioned that they can get involved with dangerous drug and relational behaviors, and those are situations where trauma can occur, and people with PTSD are more likely to develop BPD. But trauma is neither necessary nor sufficient to develop BPD, and we're very careful about making this distinction. We also need to differentiate borderline personality disorder from, from complex PTSD. And often the behaviors in complex PTSD, when somebody's having flashbacks or nightmares, they will use similar behaviors to reduce the experience of the PTSD. So we often do see dissociation, depersonalization, derealization in the patients that have comorbid PTSD. And they can also certainly have a lot of paranoia, just thinking that, the world is out to get them, or that others think of that the intentions of others are evil or bad. And then after this, we'll take a tiny little break here. So these are criteria that I see in the adolescents. They're not in the DSM, but I certainly see them with a lot of frequency in the 5,000 patients that have come through our doors. This sort of self-hatred, this seeing themselves as loathsome or evil. They actually say that they don't want to be in relationship. They would love to be in relationship, but they don't want to because they're toxic and that they will contaminate others. This profound sense of hopelessness and self-hatred again. But, people say, well, isn't that depression? But there's no other vegetative symptoms. So, they're sleeping fine and they're still enjoying, they don't have anhedonia, that they're eating fine. It's just sort of the sense that this emotional pain is going to last for a long time. And often they've been placed on many medications that haven't worked. And so they feel hopeless about therapy and treatment. They, especially the traumatized ones, can have a marked lack of a sense of continuity of time. So the way that a story is told seems to get very fragmented. Sometimes parents say that the child is lying, but often, if you think about 10 minutes of the worst toothache you've ever had, or 10 minutes of the best cheesecake you've ever had, even though both of those are 10 minutes, the 10 minutes of the toothache feels like it's much longer. So if you were to tell a story of the toothache, you'd say, oh, my toothache went on forever, whereas the cheesecake was over in a minute. So it's not that they are lying often, it's just that like strong emotions distort time. The great difficulty and consistency in performing in school despite cognitive ability. The relationships, there's a tendency to connect emotionally rather than physically or simply by gender. So we've had parents who say, oh, my child isn't gay or bi or whatever, but these children are saying, like, I'm connecting with someone who loves me. I'm less interested in their physical anatomy. They feel this feeling eternally misunderstood, this remarkable attunement to nonverbal communication. And the other thing is, one patient told me that he was like an emotional sponge. And he said, like, I can walk into a room and be feeling perfectly fine, but then if others are sad, I'll just start crying, or if others are anxious, I'll just become anxious. So it's that their emotional system is rapidly picking up, other people's emotions, and then incorporating them or integrating them as if they were their own. Okay, so what we wanted to do in speaking with the team at CTAC was that to take a break, answer some of the more pressing questions about the diagnosis before we get on to developmental aspects and treatment. So team, any pressing questions? I see, lots of
Yes.
yeah.
There is a lot of communication coming into the chat box, so really
Awesome.
appreciate that.
So
I know,
so just to say one thing about that, thank you, Diana. So by the way, first of all, thank you everybody who is with us. What I told the team was that any questions that we couldn't answer because of time, the team at CTEC we're going to compile them, send them to me as a list. I would answer them all and then return the document to the team so that you guys could get the questions answered.
great. Thank you so much. So given that, I think I'm just going to maybe go through some of the questions that were echoed by folks. So there was a couple of questions around differentiating borderline personality disorder. And I know you spoke to this, but I'm wondering if you could provide maybe then a little bit more information. Differentiating between borderline personality disorder with PTSD, with also bipolar disorder and complex trauma. So how do you differentiate between all of those four?
Mm-hmm. Yeah. And by the way, let me just say that a person can have, I've seen people who have bipolar disorder, borderline personality disorder, and complex PTSD. So the first thing is to actually go through the criteria. I mean, one of the things that used to be very upsetting to me in terms of the bipolar disorder is that the DSM has very clear criteria for bipolar disorder in terms of the length and duration of mood states. And so what will happen is I'll have colleagues who say, okay, this person has bipolar disorder, but they, maybe they were, they had a manic episode that lasted a day. Well, by definition, a manic episode can't last a day. So you want to make sure that if you're going to be, if you're going to use the DSM, then at least use the criteria that are in there. So you want to have mood episodes if you have bipolar disorder that last, the amount of time that is indicated in terms of a manic episode and in terms of depressed episode. Now, language does a tremendous violence to our experience. If you think about when you see something that is like, I'm in New England, I see a beautiful fall tree. The minute I try to describe it, I destroy it because I have to put words into an experience. So, and what do I mean? Why am I saying that? Because when you say to somebody, how are you feeling? And they say depressed. But what does depression actually mean? Like depression can mean so many different things to so many different people. And if you're going to go through the criteria for depression, that they have suicidal ideation, a loss of energy, a loss of self-care, anhedonia, disrupted sleep, psychomotor retardation, loss of attention and concentration, that's a depressive episode. But many of these, young people that I see talk about depression, but they don't have any of those symptoms. So it's not going to change with psychopharmacology. It's more of an existential despair that they experience, but we don't have another word for it. So they use the word depression. So I think that you want to be very careful as you're screening and talking to these kids about these criteria. Have they persisted for a year? What is the topography of their relationship? Are they in and out of relationship? Do they have somebody lined up before the next one shows up? When they're using substances and self-injury, is it because they want to change how they feel, etc.? So that's in terms of making the distinction between BPD and mood disorders. It's difficult with PTSD, but again, with my patients who have, with my clients who have BPD, I go through the criteria, okay, but then I also go through the criteria for PTSD. Now, the fact that somebody has experienced a traumatic event does not mean that they have PTSD. Many people can actually have had some terrible experiences and not develop PTSD. some people are more susceptible to PTSD than others are. So you want to make sure, number one, that they meet a criterion A for PTSD, which is, sort of an event that is either life-threatening or potentially threatening to the life of somebody else, or that kind of witnessing such an event. And then that they have foreshortened sense of future, flashbacks, nightmares, startle reflex, and all of those sorts of things. And as I say, people with PTSD are more susceptible to developing BPD, and people with BPD are more susceptible to being traumatized. And actually, when you have the combination of both of those, the trajectories to healing show that it takes longer to do the treatment. Now, here's why it's also very important, is that the treatment for borderline personality disorder, there are various treatments, which we'll talk about later. But the treatment for PTSD are different from the treatments for borderline personality disorder. So if you apply the treatments for PTSD to borderline personality disorder or the treatments for borderline personality disorder to PTSD, you actually don't get improvement. But it would be as if you were to say, I've got dry skin, so I'm going to give you some lithium. Applying the wrong treatment doesn't get the results that you want. So be very careful about going through the criteria, and just make sure that you're considering both BPD and PTSD. The other things that we'll see are comorbidity with OCD and nonverbal learning disabilities, and now some people are finding higher rates of autism in our clients with borderline personality disorder. But it's a very, very important question. We insist on making the distinction because we then apply various treatments to the various conditions.
Great. Thank you so much for that response. So again, there are a lot of questions that are coming in. I think at this moment, if we could just maybe move forward. It probably just seems like we've only been on for 10 minutes, but it's been close to just over 40 minutes. So at least we're going straight through 1:30. So turning it over back to you.
Thank you so much, Diana. And again, all the questions, I really want to be able to answer all of them. And so if we can aggregate them, I'll be happy to do it afterwards. Okay.
Thank you.
All right. So if we accept that certainly some of the BPD begins earlier than age 18, there's theory and cross-sectional data suggests that several temperamental and environmental contributors to BPD. So internalizing contributors are this propensity for negative affectivity, and mostly we see that these children are children who experience a lot of internal fear and distress. And then externalizing contributors, a predisposition for high novelty seeking and impulsivity and lack of constraint. Now, this is something that I've learned over recent years. This is especially true in young women, and that is that young men, well, ADHD is a precursor to borderline personality disorder because the kids are novelty seeking and impulsive and hyperactive. Young women tend to have more ADD than ADHD. They're less hyperactive. So what happens is that they don't necessarily present with hyperactivity, but they're inattentive. And what happens is that when they're inattentive, the environment, school settings, parents can say, hey, listen, you're not paying attention and stuff like that. And then they can start feeling poorly about themselves. And then, but we'll still see a lot of this high novelty seeking behavior, even as younger children with this impulsivity. So whereas before I was, opposed to using stimulants to treat ADD, I've actually found that these kids don't misuse it. And then when we treat it, they start paying attention, they feel they do better in class, they start feeling better about themselves. In the very rare occasion where there's misuse, I just stop prescribing it. And then, of course, childhood trauma, low distress tolerance are major contributors as well. When we look at retrospective studies, adult BPD is associated with childhood externalizing behaviors. even though retrospective reporting does not allow determine the precise window of risk, one of the things that I have to say is that I definitely see a spike around puberty. Nothing known about the genetic and environmental overlap, although some researchers have said that temperament and emotionality is about 60% genetic. Again, a few studies testing heritability, affective dysregulation and behavioral under control is somewhere between 40 and 60%. So, I mean, I think human behavior is so difficult. It's not like eye color or height or something like that, that there's going to be a single gene, but you definitely see, you know, we're going to try to understand this a little bit more with genetic testing and studies, but that temperament does seem heritable, so that there are some, you know, genetic indicators. And again, that ADHD is a big risk factor for BPD. And the only reason I say this is that, you know, is especially if there's ADHD and trauma, and in family members where there's a lot of emotionalities, just, you know, to keep an eye on and think about whether BPD might be a possibility in the child that's presenting with suicidality, self-injury, etc. There was a really interesting study where this psychologist in Florida was just looked at non-clinical sample of twins and just assess for BPD traits over time, and looked at internalizing and externalizing psychopathology at 11, 14, 17, 20, and 24. And what happened is that, you know, because a lot of the behavior that you see in adolescence can, you know, I mean, if you think about, you know, substance use or eating behaviors, that, you know, you're going to see this in adolescent in any case, so that people could be misdiagnosed as having BPD, but so that there was an overrepresentation of sort of BPD behavior. But then over time, these behaviors, even with nothing happening, these are non-clinical samples, the BPD diagnosis just simply drops off. So, you know, you could, you know, sometimes people say that the reason we've been very successful is that, you know, we treat young people up until 20, 21, 22 or whatever, and then, you know, they go off into the real world, and that even if we'd done nothing, you know, they might have gotten better on their own. However, remember, this is a non-clinical sample. The people who come to us are people who have made multiple suicide attempts, lots of hospitalizations, lots of self-injury. And by the way, we don't have a quiet room. Our doors are not locked. We don't do any restraints. We haven't done any in 15 years. We don't lock kids up. We don't inject them. We don't restrain them. But they're, you know, much more ill than this kind of a non-clinical sample. But just to say that, you know, that impulsivity and externalizing behaviors naturally will drop off as the child ages. Okay. Well, okay, so let's talk a little bit about treatment modalities for BPD. So let me just say, because I actually had a really interesting discussion with the CTC team, that I am a therapist that does dialectical behavior therapy, DBT, and I realized that I'd focused a lot of my talk on DBT, and you know, perhaps at the exclusion of other modalities. So let's just talk a little bit about treatment modalities for BPD. Okay. So, so here's a chat-in question. What are some of your concerns around working with youth with borderline personality disorder? And then use the chat box feature to share your responses. And Diana, are we just collecting those responses, or will you share some of those with me?
Sure. As people chat them in, you should be able to see them on your chat box, but okay. I can definitely verbalize some of those. So some of the things that are coming up are burnout, misdiagnosing.
Yeah. Mm-hmm. Yeah, burnout. And this is one of the biggest concerns that I see in terms of working with people with BPD is that colleagues tell me about burnout. And so if you don't have an environment that targets burnout, I've been running this unit. I've only been seeing people with severe BPD for the last 15 years. I was talking to some colleagues and they said, you talk to suicidal people and you've been doing that for 15 years. Like, you don't look that old. You don't have any gray hair. And I said, well, why should I have? And he says, well, I mean, listening to all those problems all of the time. And I say, who listens? No, I don't say that actually. But the thing is, I have a very strong supportive team who, around me, who sort of help me and I help them and we help each other around a burnout. But that is absolutely the number one concern that people describe in terms of working with these adolescents.
Yep. And I'll just very quickly go through some that are coming up. How to engage adolescents, how to actually diagnose in the sense of the concerns around stigma, both from the recipients of the label, but also, as you mentioned beforehand, at a societal level and also within the behavioral health field. The inclusion of the family, right? So how to support the family, any additional needs that might come with that sort of diagnoses, reinforcing behaviors unintentionally. So yeah, definitely a lot, and we'll definitely collect and send them to you.
I mean, like, this is like the brightest audience I think I've ever had. It's like, these are such brilliant questions. Okay, let me just address this question of stigma, which is, I think, so important. First of all, in our research, let's say that you go to the doctor for whatever reason, and she tells you that, you say, I've got a sore throat, and you say, well, she says, okay, well, there's nothing wrong with you, or you've got something wrong with your throat or whatever. How unsatisfying that is. And for two things, or three things. One, when we diagnose a person correctly with BPD, in 80% of cases, the amount of relief that they experience is remarkable. Because the other thing is that it's our profession that has stigmatized this condition. If you go in and you say, oh, you have flu, well, you don't care. Thank you. Okay, now I know what I have. Back in the day, when people had HIV, they had HIV, but then medicine stigmatized it because we said a lot of things about, oh, it means that you're doing these behaviors or whatever it is, or we called cancer the C word or whatever it is. So the stigma has come from our profession, not from the people themselves. The other thing is this, is that, like my son was saying, hey, what do you think about this 3.4 billion hashtags for on TikTok for BPD? They're going to turn to other sources. And there's a lot of celebrities coming out now with BPD. I don't know whether they have it or not, but a lot of people are identifying with them. Secondly, when you prescribe a treatment, if you say, okay, a person has dry skin, and then you say, okay, here's an ointment. They'll say, what's this ointment for? And you say, I'm not going to tell you what it's for. But then they say, oh, it says it's for dry skin. Then they're going to say, okay, do you think I have dry skin? So if I say I'm going to prescribe dialectical behavior therapy, or I'm going to prescribe mentalizing-based therapy, a lot of these young people are going to turn to the internet, and they're going to look up these treatments, and they're going to say, oh, it's for this condition. So they're going to find out about it in any case. And so I just think I'd rather have the discussion as a caring therapist with them rather than them turning to the internet. The question about how to engage kids, we get so much engagement and motivation for treatment. And people say, how do you do that? See, the thing is that often when kids come here, you say, okay, I'm going to help you with your BPD. They roll their eyes. I say, why did you just roll your eyes? And they say, well, because everybody tells me they're going to help me with the BPD. And I said, well, what have they done? They've talked to me, or they've given me medications, or they've put me in groups, or whatever it is. And I said, well, why hasn't that helped? He said, because it doesn't help me with my emotional feelings, my suicidality, all that. But when you prescribe a therapy that is helpful to that person, somebody comes in with pneumonia and say, this is an antibiotic that's going to cure pneumonia, people are going to be motivated to do that therapy. So, so the engagement has to do with tying the treatment to what the person wants to work towards. And when you do it that way. And you say, I know that you don't want to suffer because that's why you're here, because you've been suffering. And I've got a therapy that's going to help you with your emotional suffering. They rapidly engage. But if I say, okay, I'm going to just talk to you every day, or I'm going to tell you to do push-ups, or whatever, or I'm going to tell you to take this medication, it's very hard to engage. So you have to tie why the therapy that you're doing is going to help the symptoms that they're concerned about. And then finally, the question about family is very important. We won't actually treat a teen or adolescent if their family isn't involved. Mira, yo hablo español, y si conducto esta charla en español, no me vais a entender. Some of you will understand me. But I have to speak the same language as you're speaking in order for us to be understood. And so when we're treating adolescents, we insist that the family become involved as well. So we're not treating like the so-called identified patient. The identified patient is the entire family. Winnicott said that there's no such thing as an infant, but there's no such thing as an adolescent. The adolescent is because of their engagement with their family as well. And once the family is involved, and there's a lot of psychoeducation and validation, you see psychopathology begin to come down. All right, so Diana, I'll move on, and then you'll collate those questions, and then I'll be able to answer some of them offline.
Absolutely.
Okay, awesome. So what are the impediments to treatment? Adolescents with BPD commonly seek clinical help, but opportunities are frequently missed, and they're missed because people don't diagnose it. Clinicians often consider it controversial to diagnose personality disorders in adolescents. That these diagnoses are frequently either discouraged or made too late. And the brain learns by repetition. When you have repeated that you hate yourself for years, that no one's ever going to love you for years, that you don't know how to regulate your emotions other than through cutting for years, you become good at those things. But from a dialectical behavior therapy perspective, one of the ways that we see things is that we see the disorder as a skills deficit, that people would do better if they knew how to. So that if we can teach them the skills to be able to manage those things earlier on, then we're going to prevent the evolution of this full diagnosis. Treating adolescents with BPD can cause considerable stress and strong emotions in clinicians. We talked about burnout, and that adolescents with BPD often struggle with interpersonal relationships, including the therapists. And being on the receiving end of being devalued is very, very painful, and it may be difficult to remain engaged in therapy. There's been only one study at early intervention. It's a form of therapy called cognitive analytic therapy, which has some cognitive elements and psychoanalytic elements. And they followed a group of young people who were at risk for developing borderline personality disorder. And at the 24-month follow-up, the patients in the cognitive analytic therapy group had lower levels and significantly faster rate of improvement in internalizing and externalizing psychopathology compared to the group who received treatment as usual. This is a group out of Australia. It's a very interesting form of therapy. In the United States, I think it would be difficult to conduct this kind of study because we don't have a healthcare system that supports universal healthcare. And so, to conduct long-term studies, you need, sort of a lot of money. But CAT was one early intervention study that showed a reduction in BPD psychopathology. So these are the forms of therapies that have been studied in adults. DBT is the main one that has been studied in adolescents. So that's why I like to use evidence-based therapies, but the ones that have been used in adults for borderline personality disorder are schema-based therapy, cognitive behavior therapy, mentalizing-based therapy, transference-focused therapy, acceptance and commitment therapy, interpersonal group therapy, the STEPS, systems training for emotional predictability and problem solving, and manualized cognitive therapy. Now, what about medication? I'm often asked about medication. There is no evidence at all that medication is useful in treating adolescent borderline personality disorder. However, earlier on, I was talking about ADD, ADHD. Certainly, there can be comorbid OCD. Certainly, there can be comorbid PTSD. There can be comorbid depression. If there is comorbidity that is treatable with medication, I treat with medication. But for the core symptoms of borderline personality disorder, there is no medication that to date has proven to be effective. Now, whatever therapy you do, and again, like if I found that dancing cured BPD, I would have everybody dancing. So the simpler, the better. But whatever you do, there's 5 functions to any comprehensive therapy. You have to enhance the client's capabilities. So people have capabilities. I have people who are artists, who are musicians, who dance, who do other things. Enhance the capabilities that they do have. You want to improve the motivation to change. And often when they've had poor treatments or treatments that don't really help them change, they aren't going to be motivated. Ensure that the new capabilities are generalized from therapy to clients' everyday life. And one of the things that used to happen before I started my program was that I would be on inpatient units and people with BPD would come in and they would be behaving fantastically. Well, of course, if you take away all of their stressors and keep them in rooms and feed them nicely, then, there's much less stress. So they're not going to, be as dysregulated. But, when you teach your adolescent how to drive, you teach them in a parking lot, but that driving has to be able to be driving on streets and driving on highways. Otherwise, it'll never be generalized. And the same thing with the skills and with the therapies. Like they have to be able to take what they learn to the outside world. Enhancing the therapist's capabilities and motivation to treat clients effectively. Again, I like that question about burnout, because when you don't have the skill set and when you don't have the motivation and you're feeling burnt out, you're rapidly going to say, I'm not doing this. So we have to enhance the therapist's capabilities and motivation and structure the environment to support the clients and therapist capabilities. So, so by having groups, by having support for the therapists, we don't turn to environmental interventions as much. We do less for the client, but we teach skills, and that often has to do in more of a structured setting. Okay, so I'm just going to say a few things about DBT, the therapy that I use, and Dr. Marcia Linehan, a dear colleague and friend, developed this. So she had been trying to help the most seemingly untreatable and unwanted group of patients, which is suicidal clients with suicidal clients. So she tried CBT, and then what often they would say is like, you're just telling me that I have to change my behaviors, that I need to just get up and go to work and not have the thoughts that I'm having. And they felt very invalidated and actually became more suicidal. And then she turned to more of a talk therapy, a Gestalt therapy, a very validating, supportive therapy. And what they would end up doing is that they would leave the session and say, I felt so heard and I felt so validated, but I still don't know what to do with my emotions. So on the one hand, if she taught them how to change their emotions, they said, you're pushing me too hard. And if they said, I'm listening to how hard it is, they say, okay, but you're not teaching me what to do. So then she integrated these two approaches into dialectical. One, that is both listening and accepting the person as they are in that moment, and encouraging them to change at the same time. We love the use of dialectical behavior therapy in adolescence because we teach it in a classroom-like setting. We teach about emotions, and we teach the skill sets of emotion regulation, of distress tolerance, interpersonal effectiveness. And so these are young minds that are used to learning, and we teach them the skills, and then we teach them how to apply the skills. And it's like anything. I mean, I'm always mesmerized by young children when they learn how to play guitar and piano, y aprenden cómo hablar español and other languages. And, but, like now I can't learn how to do anything. My children are terrified that I try cooking. They think it's like going on intermittent fasting when I have to cook. I do try, but it's harder, I think. DBT structures the therapy in a way that targets very dangerous behaviors first before getting into the rest of their life. We don't, people often talk about the root cause, like what's the root cause of this person's problem? But if you think about what's the root cause of your whatever something that you're struggling with is, maybe it was an invalidating parent, but that parent didn't come from nowhere. That parent came from somewhere too. So even root causes have causes, and all the root causes that have causes also have causes. I mean, if you want to go back to the original root cause, it's either the Big Bang or the Garden of Eden or one of those. Because I mean, without that, then there's no this. So rather than spending time in this stage looking for these so-called root causes, it's saying, this is your life as it's been handed to you with all the things that have happened. What can you do with it now? And then the other thing is that DBT targets symptoms such as impulsive aggression and self-injury, which are very high in adolescents. We get a strong commitment from adolescents who want to do DBT, and that is to sort of say, okay, look, you've got a choice here. You can continue to live your life the way that you're living it, or you can do things differently. Now, I can teach you ways to do things differently. These are going to be more effective long-term, but they aren't going to work as quickly as drugs or self-injury or sexual encounters. So can we do pros and cons of doing the treatment, or pros and cons of not doing the treatment? And we use various commitment strategies to get the person engaged. We tie the therapy to what the young person wants for themselves. The other thing is, often, parents will say, okay, this kid needs therapy. And I'll say, okay, kid, do you want therapy? And they say no. So I say, okay, well, I'm not going to do therapy if you don't want therapy. It has to come from, they have to see the wisdom in it for themselves. And often they'll be very surprised because they're saying, wait, you aren't going to do the thing that my parents told me to do? I say no, because that's what they want. But if you don't want this enough for yourself, then I don't know how to engage you enough. But however, I do have a therapy that I think could be helpful to you. But we won't accept somebody into therapy if there's no commitment to change. It would be like if you have diabetes and you say, well, insulin's going to help you. You say, but I've got no commitment to take the insulin. Well, I don't know what to, I suppose, a parent could inject a child, but there's no way to force therapy into a kid. Again, we target life-endangering behaviors first, hospitalization, self-injury, suicidality, treatment-interfering behaviors, and we spend a lot of time because the problem is that people will say, well, I want to talk about my trauma, but the problem is when you talk about the trauma, it will often elicit such strong emotions that then suicidality and self-injury appear. And with some degree of irreverence, I'll sometimes say to a young person, look, you want to work with on your trauma, and I want to help you so much, but I can't help you if you're dead. So I need to know that you can reduce the self-destructive behaviors, the suicidal behaviors, before we tackle some of these other things. And so we want to make sure that a person has the capability for emotion regulation and distress tolerance, etc., before getting on to any kind of processing type therapy. This slide here, I was trained in psychoanalytic therapy, and this slide here that was explicit in DBT switched me to DBT. One is that people are doing the best that they can. Every single one of us at this point in time is doing the best that we can. people often say, well, how can that possibly be? Because I've done better at other times. And it's because your conditions right now, maybe you're tired, maybe it's been a long day, maybe you've got someone who's sick at home. These are the best that you can do right now. And when I think about that, rather than thinking that someone's out to get me or they're doing terribly or whatever, I feel better when I think of people doing the best I can, because I know I bring the best of myself to every situation under those conditions. So when I see people that way and they see me that way, it just, even if it's not true, it's just a better way to think about things, that people want to improve, they don't want to suffer, that they must learn new behaviors in relevant contexts, that they may not have caused all their problems, but it's theirs to solve anyways. That sometimes you say, well, I didn't do this to myself. I wasn't the one who abused me. But you know what? At the end of the day, if you're waiting for that other person to do something, it might never come. But you are empowered. You have agency in changing some of those aspects. And to always remember that people who are struggling with suicidality are living lives of tremendous, tremendous suffering. Diana, I think that we decided to leave the rest of the DBT slides at the end, that we could send to all the attendees so that we could leave at least 15 minutes for questions.
Yes.
Or what do you think?
Yeah, so I mean, given that you have very kindly offered to answer some of these questions, I think maybe we can go a little bit more in content. For folks, we will have the recording and the slides available in 2 to 3 days. The responses to the Q&A will definitely take a little bit longer, so we'll be in touch about that. But I'm wondering if maybe we could move to the AVA in treatment, because there have been some questions and concerns around how do you get the family involved? What role do caregivers play as well? So I know that's the very last section. So wondering if you could maybe do that in the next
okay. So we talked about the AVA previously. So we want to enhance AVA's capabilities, improve the motivation to change, ensure that they are generalized from therapy to everyday life, enhance capabilities, motivation to treat AVA, and structure the environment to support AVA. One thing, it's interesting. I just came from seeing a client in our partial program, and I said, did this program help you? And she said, yeah, it helped. I said, did you seem a little bit skeptical? She said, well, it helped quite a bit, but much, much more than it helping me. She said, I knew a lot of this stuff, is that it helped my mom. My mom sees me differently now, and she understands the disorder. She understands what is helpful and what is not helpful. I love this quote from Michelle Toomey in The Power of Language. Words can inform our mind, caress and comfort our feelings, excite and thrill our spirit, or warm and kindle the flame of our hearts. They can also slap our face, punch us in the stomach, rattle our nerves, kill our desire, or destroy our self-confidence. And so many of the kids who come to our program, through the very, very, very well-meaning action of their parents, maybe they had a very successful sibling, and they said, if you only studied as hard as your sibling did, or if you weren't such a baby, not, can you just get over it, or things are going to be okay, is that all of these things for, they work well for the kid it works well with, but not for the kid it doesn't work well with. So one of the things to do is really, and I would implore, that all of you as clinicians, really refrain from using these terms: manipulative, attention-seeking, gamey, promiscuous, acting out. Maybe even the very word borderline. Some people have a problem with that, and I certainly, that's a time for maybe a separate discussion, because these terms do not have clinical application. These are non-clinical terms. Somebody once argued with me that manipulative was not a pejorative term. And right in the middle of grand rounds, I actually got onto Google News, and I put in the word manipulative. There was manipulative bankers, manipulative politicians, manipulative hedge fund managers, manipulative teachers, all of whom had done something not good. There was not manipulative Mother Teresa gives lots of food to the hungry. So this term manipulative is pejorative. Attention seeking, teachers will often say, hey, kid, pay attention. The kid is always paying attention. What the teacher means, pay attention to what I'm writing on the board, not, stop paying attention to the interesting squirrel or ambulance that's outside the window. So, that often behavior isn't attention seeking. What does gamey mean? What does promiscuous mean? And often it's differentially used between male and female and other clients. What does acting out mean? That these are non-descriptive terms. So be as descriptive as you can be. The other thing is this, is that, I remember when my friend said that he wanted to get me to run a marathon. I eventually did. But I thought when I was young that I could just run a marathon, and I stopped after a few miles because I was hurting so much. But go slow. It is, language acquisition, music acquisition, skills acquisition, take time. Set short, realistic goals, because I think that once a person when I ran my first mile, then I thought, okay, I can do 2. When I can have my first healthy discussion with my parents, maybe I can discuss other requests. Remember that strong emotions beget strong emotions, and that, that emotions are contagious. So if your client's dysregulated and you're dysregulated, that's going to lead to a cycle of dysregulation. But in the same way, if I am regulated, that can be soothing and settling for my client. The other thing is that parents and therapists often say, okay, you need to use your skills right now when the person is dysregulated. But imagine that you only learn to drive in the middle of a highway, or that you only learn to swim when you were drowning. You want to learn new skills when things are calm and not in the heat of a fight, so that when you need them, they're there because you understand them and because they've been used and applied. Never ignore self-injury or suicidal acts. The other thing is to set limits with your own tolerance. I often will see people who are burnt out because they don't like a person's behavior. I've kicked people out of my office because they were, in my opinion, rude. They were insulting, they were disrespectful. I said, listen, you know what? I want to help you, but if you're going to call me an effing this, you can leave. We can reschedule for next week, but other people might not care what language is used, but you set your own limits. Doing the wrong thing for somebody, doing the wrong thing for yourself is never doing the right thing for somebody else. Doing the right thing for you is doing the right thing for somebody else. So often we'll think, okay, I have to sacrifice myself, but you become resentful in the long run. So never tolerate abusive treatment, tantrums, threats, hitting, or insults. And the other thing is, I screw up so many times. And when I get something wrong or I say something invalidating, I just admit that it is. If it's true, I'm not going to admit to something that I haven't done. But don't become defensive. Often I see my colleagues or other therapists become very defensive, trying to be righteous. It's, we're human beings. We have good days and we have bad days. And actually it models for these young people that we can make mistakes and still. I have my report card here from my first year in university. People think of me as a personality disorder expert. My first semester, I got a D in psychology. What psychology? Psychology of personality. Okay, well, here I am in any case. It's okay. We can make mistakes and we can still succeed. So I think that this is where we, Ava and her caregivers, how do we help her and her caregivers? How do we help the caregivers respond to those challenges? Psychoeducation is so important, and it is true of medical education, whether it's of any chronic illness, diabetes, asthma, Crohn's, inflammatory bowel disease, all of these things, is that the more educated you are, the better you are at dealing with people's challenges. And so when we teach people, the one skill that parents this would be if we were to do a discussion on DBT. The single thing that the majority of parents of those 5,000 families have said is that validation is the single best skill that they've ever learned. So it's just recognizing that a person's experiences are real for them. So we teach we teach parents about their own self-regulation, about their own emotional regulation, about their own setting limits, about how to listen in a way that the child feels heard. And while we're teaching the child the skills. So it's a very interactive process where everybody is learning the same material. All right. So this is what the research shows, that adolescent BPD looks a lot like adult BPD, particularly in female patients, clients. The symptoms are based on skills deficit rather than intentional acting out. When working on goal setting with a client, always include the client in identifying what needs to be done. I never have the parents come in and say, okay, my kid needs to stop smoking weed or something like that. No, the client has to come in and say, this is my goal for treatment. Rethink terms like manipulation and promiscuity. In fact, try to get rid of those in your vocabulary. Rather than say promiscuity is like the child had 3 sexual encounters with older people in an unknown setting, and then think about the dangers of that rather than saying you're promiscuous. The earlier the intervention, the better. And that DBT certainly has been effective in the group of patients and clients that we treat. And then I've got these resources. Over here, I have the various modes of treatment, but you'll get these in the slides that will come to you, because it's about the specific methodology that we use.
Great. Thank you so much. Really appreciate all of this content. There's a lot of chatter in the chat box here, and there's a lot of, thank yous for your presentation. As was just mentioned, there is the resources section, these DBT modes of treatment, as well as other resources as listed here will be available. There are also additional slides on DBT skills modules. But at this point, I'd like to go to the Q&A slide. We don't have that much time left, but I would like to attend to some of those questions. So on slide 62, please continue to put in your questions. I do thank you for taking the time at some point to answer those questions. We will have them posted, but we certainly will need a little bit more time before we are able to address those. So going back to the very beginning, what screener tool is available to accurately diagnose a client with BPD? So I know there was a lot of questions around how do you differentiate, but how do you now become more concretely? Is there a screening tool that might be available for folks?
Yeah, the one that we use is called the MSI, which is the McLean screening instrument. That seems to have reliability in both adults and in children. There are other ones that other people have used, but interestingly, some of the other ones which are often used in research, I won't name them, often leave out self-injury and suicidality, which in adolescence is one of the hallmarks. So I have my own preference is the MSI.
The MSI, great.
And it's 10 questions, so it's quick.
All right. Our next question, do you notice families facing challenges when their children might rise to the level of being taken to the hospital for an evaluation, but then the hospital categorizes the incident as, quote, behavioral rather than mental health, and will not provide additional time, support, services, assistance, etc.? Yeah.
Listen, I try to be as non-judgmental as I can be. I try to believe in the best in people, but I have a problem with that hospital that is, quote unquote, describing it as behavioral. I mean, it sort of implies that there's a dualistic system. There's a kind of a mental system and a behavioral system. when we think in duality, we get into polarization, and it's one of the big problems of what's happening in this country today is we're so polarized, and this idea that behavior comes from nowhere is inconsistent with the facts, and it is it's I'm very saddened for that family to say, oh, this is behavioral, because that behavior is a manifestation of something that's going on in the brain. Or it's a response to something that's going on in the child's environment that is often maladaptive and shows ineffective skill ability. So, you know, I do think that it's on us to be advocates for our clients and their families, to teach correctly, and to you know, to continue to advocate. I often will go to emergency departments and teach stuff like this so that that these families aren't turned away. But it is you know, we have to do this with compassion as well, so that they, you know, that understanding that this is often what emergency departments have been taught as well. But it's very frustrating. My heart goes out to those families because I hear that as well a lot.
Great, thank you. And as we move towards wrapping up, what is the outlook for an adolescent with BPD?
Excellent. You know what? Here's the thing: is actually it's a good prognosis diagnosis. With early intervention, we can really prevent the development of full-blown BPD. What you're going to do is you're going to turn a sensitive child with a massive skills deficit to a very effective and skillful child. And even in Mary Zanarini's research with adults with BPD has shown that, you know, that symptoms go into remission within 2 years. I think remission rates, it makes a distinction between recovery and remission, but, you know, somewhere between, I think up to 80%, and over time it continues to improve. There are some things, you know, like self-loathing. That's my final frontier in this field, is like how to target self-loathing. None of our therapies target self-loathing, and that is, to me, the saddest of all the symptoms. We need to do a better job of doing that. But over time, I mean, I have many clients who've former clients who've completed medical school and social work school and gotten their PhDs in psychology. And one of my clients is now an excellent DBT therapist and continues to see me. So the outcomes are, you know, great. And certainly in our populations, we've seen a massive reduction in suicidality and self-injury. So, you know, whereas, you know, other conditions like perhaps autism or schizophrenia or other conditions, you don't see the level of recovery that you do in BPD.
Great. Thank you so much for sharing that. So again, I want to remind folks, there has been an offer, very kindly, really do appreciate you taking the time to answer the questions that we just did not get a chance to do. So we will be posting that at some point in time. Please give us some time for the turnaround for that. Within 2 to 3 days, you will be able to find the slides. If you can advance this to slide 63, and I know, you know, people are starting to log off, but I do want to say that we do have a survey that will be coming up on the chat box a little bit. If you can take the time to really fill it out, because this offering was a result of your feedback. What are the needs that you're seeing now on the ground? So if you can take the time to fill out the survey when it pops up.
You mean this one?
Yes, please. And I'm going to turn it over to my colleague, Janet, the one that said upcoming events, please.
Okay. Upcoming events. Yeah.
Okay. Thank you, Dr. Gary Blaze. Thank you so much for answering all those questions and for a great presentation. Thank you to everyone attending today's webinar. And the slides, as Diana said, the slides will be up on the CTAC website within the next 2 to 3 days. And we also invite you to join us for our upcoming events. And you can visit our website for a full list of all of our upcoming events. And once you leave today's webinar, you will receive a feedback survey. We will really appreciate you filling this survey out, this form. And on behalf of CTAC and our presenter, thank you for joining us today, and have a great rest of your day. If you have any question, Any other question, please contact us at ctac.info@nyu.edu. Thank you. This was very great. And I thank you all for all of your wonderful questions. Yes.
Thank you so much.